We welcome you to what will be our last CME program for the calendar year 2025. The program this evening is again Dr. Holstead, who was with us 2 weeks ago. This evening, he's going to be talking about appropriate care of envenomated patients. The program this evening is credited for 1.5 hours of physician CME. If I can get my slide, there we go. Category 1 AMA CME for physicians and 1.5 hours of CE credit for Virginia Nurses Association. Sovah Health's accredited by the Southern State CME Collaborative for physician CME and by the Virginia Nurses Association for nursing CE credit. The program tonight is developed with certain desirable physician attributes, including our delivering patient-centered care and employing evidence-based medicine. The needs assessment for the program this evening was the public health issue and concern for venom-related injuries that occur. Dr. Holstead, myself, and members of the Sovah Health CME Committee have no commercial relationships to report to you. This program does not have any commercial support. Instead, like all the programs we provide through Sovah Health, is supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, upon his retirement in 1985, set this fund up, which allows to support honorarium for speakers and their travel for live events for programs for healthcare professionals within our community. You will receive by email this evening, or you can click on and receive it through the chat through a QR code, a program evaluation. We ask everyone to take a few minutes to complete that. There's some 7 or 8 questions. One of the questions, number 4, asks what changes may you be making or will you be making based on what you learned this evening. This is for everyone, not just the physicians. Everyone practices their craft in medical care based on their scope of practice. So take a few minutes and give us what you think you'll be doing differently from what you've learned this evening. The form also asks you to enter your name and email address again. Please give us your full name so that we can have that for the CME certificate that will be subsequently sent back to you. If someone's on the program tonight with you through your login, please let myself or Mary or Jennifer know so we can be sure they get credit for their attendance. Mary will also put into the chat box towards the end of the program a QR code that allows you to get the eval form if you prefer to get that, though you will still be receiving it by email once the program's completed. For Sovah Health residents, you do not have to keep up with your CME certificates. Your program coordinators do that for you. I like to always remind the nurses and nurse practitioners that the Virginia Nurses Association does require you to provide an eval form in order to receive your CE credit. That's not the case for physicians, though we hope everyone will send us a form that's been completed. We use this information not only to evaluate the program you've attended, but in our planning for future programs. Each time we do a program, I always want to take the time to thank Mary Ken and Jennifer Goodman for their tireless efforts and us being able to produce these programs. They truly do all the magic that makes these things happen, particularly as we do them virtually through Teams. I know Dr. Holstead is going to enjoy answering your questions or receiving your comments. If you'll put those into the chat at the end of the program, he'll address those. I'm sure I know he wants you to ask as many questions or provide any comments you want. If you do it verbally, we do ask you to mute your phone to listen for the response so that it doesn't create a lot of feedback for us. But we're not having any programs in December. That's mainly because we have great respect for families and activities that are associated with the holiday season. We will restart programs in January, and we'll be sending out a notice about mid-December about the programs that we will have beginning the 1st of 2026. just to take a moment and wish everyone on the call happy holidays as we enter that season with Thanksgiving and then the Christmas, Hanukkah, and the other celebrations in the coming weeks. Please enjoy it with your family, and we hope it's a happy and nice time for everyone. That leaves me the true honor again of introducing Dr. Christopher Halstead, who is the medical director for the Blue Ridge Poison Control Center. He's an ER physician at the University of Virginia and also vice dean that manages student activities for the university, particularly the School of Medicine. His educational journey began in the Midwest, completing his undergraduate chemistry degree at the Calvin College in Grand Rapids, Michigan, and then receiving his MD from Wayne State University. His emergency medicine residencies were completed at the Michigan State Butterworth Hospital System, and that was followed by medical toxicology fellowships at the University of Indiana. He also is a product of the Leadership in Academic Medicine program at the Darden School of Business at the University of Virginia. He has received numerous awards for his teaching, his research efforts, and his commitment to doing the very best things in healthcare. He's received the Thomas Jefferson Award, which is given to those members of the University of Virginia who've exemplified the principles and mission of the university and of Mr. Jefferson. In addition, he's a member of the Raven Society, which is a distinct honor for UVA faculty and students. One of his other accolades is he teaches a major course in wilderness medicine, both for undergraduates and for medical students and graduate fellows. So he's a real expert in what we're going to be talking about tonight. So we're delighted to have him come again. This is one of his several programs for us. And tonight he'll talk about envenomated patients. Dr. Halstead, thank you so much.
Dr. Barr, thank you. I'll bring my slides up here a minute, hopefully without a problem.
Looks good. Looks great.
Looks good?
Switch. We're seeing your follow. There you go.
All right, thank you.
Looks good.
Thanks, Mary. Good. No, hey, it's an honor to be back. Fun to talk to you about this topic. For those of you who enjoy the outdoors, I'll try and relate this back to you. I'm keeping this focus certainly on Virginia. I have no conflicts of interest. I have no investments of anything that I want to talk about. I'm not going to talk about any specific products other than at the very end, the snake antivenoms, because there's only 2 on the market right now, just to be aware of those. As Dr. Moore said, I cover the Blue Ridge Poison Center. Last time I spoke, I mentioned this. You can see where we cover the blue area, where Virginia Commonwealth University, our good friends and colleagues there, cover the yellow area. And we cover a very remote rural area as we look at central and southwest Virginia, where a lot of these animals reside. And I think it's just fascinating what we have in nature. And I try and spend all my downtime out in nature. One of the things we recently did is partnered with the Virginia Master Naturalists. And you can have access to these. We did this for the public. We started with a project called the Socrates Project, which is the poisonous plants in Virginia. Developed a book, worked with the Master Naturalists. We did the toxicology component of it, and they did all the natural components of it about these plants. Phenomenal collection of pictures from people from all over the state that we got. And that's online, and it's free, open to anybody. We then followed up with the Cleopatra Project, which is partly what I'm deriving some of this talk from, which is the poisonous and venomous animals in Virginia. And I'm glad to say we have been working on the Claudius Project for some time, the poisonous mushrooms in Virginia, and that will be coming out this December and will be linked to the Poison Center like the other 2 are. So very excited about this. It's been a fun project with the Master Naturalists, and I'll talk about some of these things and give credit certainly for some of the pictures from them. Some cases. So I'm going to try to do this mainly case-based. For those of you who go out in nature, which we're really encouraging at the University of Virginia, As a physician, I really firmly believe, and so did Thomas Jefferson for that matter, that nature actually is good for us. It's good for us to get out. It's refreshing. We're really doing some unique things with the students to try and encourage them to take advantage of the University of Virginia and the nature that surround us, including the mountains, Shenandoah National Park, the national forests and such. However, there are certainly things in nature that you have to be aware of. So as we go through each case, think through what you might have with your patients as we talk about these. So the first one, leaning against a tree. A 26-year-old male presented with acute onset of painful rash on his arm after he brushed against a tree while hiking in the Blue Ridge Mountains. He felt immediate pain on his arm like electric shocks. He denied any other complaints. The clinical exam reviewed this. You can see the lesions on his arm, which after a couple hours looked like this, was bruised, painful, and a few days later developed pustules. And what I don't think many people realize is that we have a number of pus caterpillars. And so he had a buck moth envenomation. The caterpillar to the right is one that was very similar to what he had that envenomated him and that he brought in. And it looks like it's hairy, but in fact, those are venom apparatus that are on the buck moth. And probably the buck moth is the one that I have the most encounters with, both in nature and in clinical practice. It's prevalent throughout the United States, but certainly in Virginia. The caterpillars actually transmit their venom through these urticarian hairs, distribute over their bodies. The spines are really thin, they're hollow, and they tend to break off, which is part of the reason why they become pustules, because they're embedded in the skin and you get a pustule around that. They're characterized, they include things like histamine and histamine releasing substance, which is why you get these really kind of erythematous, painful initially, but then itchy dermatitis. And you have to let the patients know that will go on for some time. They can use a steroid cream, but they should also expect to get some pustules and not to treat with antibiotics. It's not needed. You can use tape early on if you do get envenomated to try and take out some of those spines that are there, but otherwise it's just symptomatic supportive care. It's not just the buck moth. There's other ones in Virginia. There's the black-wave flannel moth caterpillar. There's the grapeleaf skeletonizer caterpillar. There's the hickory tussock moth caterpillar. There's the Io moth caterpillar. And one of my favorites, the saddleback caterpillar, which I find every so often on my hikes. And you have the southern flannel moth caterpillar, which is also known as the official pus caterpillar that actually looks fuzzy. And you have the spiny oak slug caterpillar. And you have the white flannel moth caterpillar. So there's quite a few out there that you can run into, and you may not realize that the caterpillar that's hairy, actually, those are urticarian hairs that have a venom apparatus. Actually, I had one of my sons, I think I mentioned this before, I have 6 children, 5 sons and a daughter. We did a lot of camping, and one of my sons leaned against a tree and had actually one of these caterpillars fall down his shirt, which caused a lot of screaming. Certainly his brothers thought it was hilarious, but you will run into these in nature if you're outside enough. Changing gears. 26-year-old male presents with a history of painful fluid-filled lesions around the right eye for 2 days. Apparently, it was asymptomatic 2 days prior when, on waking up from camping, he complained of burning sensation associated with redness over the area around his right eye. In the next few hours, he noticed eruption of some fluid-filled lesions over the same area associated with pain. He's consulted his general practitioner, who diagnosed him with a case of herpes zoster ophthalmicus and started a tab of acyclovir, 800 milligrams, 5 times daily, but the lesions continued to progress. On detailed history taking, it revealed that while sleeping, he felt something crawling over his left arm and tried to remove it with his right hand. He noticed burning sensation and redness followed by eruption of fluid-filled lesions around his right eye the next morning. Examination reviewed bullae, numerous tiny vesicles and crust over erythematous and edematous upper and lower eyelids in the area around the medial canthus of the right eye. Unaided examination reviewed uninvolved cornea or conjunctiva and a negative Hutchinson sign. There is no photophobia or vision change in both eyes, were normal. Examination of other sites revealed involvement of his right arm of a kissing lesion. And this is blister beetle dermatitis. So the beetles do reside in Virginia. There's a number of different families. And there's two. I think the one that is best known is Cantharidin, the vesicant that is in two of the families. And it's a potent vesicant and an irritant. So when an insect comes on you and you disrupt it or potentially try to kill it, or if you're sleeping and happen to rub your eye and break it, they will release this substance that caused the blistering. And in history, if you like history, it's for ancient times was used as an aphrodisiac. And for the life of me, I cannot begin to figure out why they have used this as an aphrodisiac. And in my toxicology practice, we've actually had people run into complications thinking that this should be used as an aphrodisiac. Just to give you another example, you can see these blistering lesions that are on his neck. And if you look on his arm, the kissing lesion, meaning that something was there, bent the arm, and let off secretions from the disruption of the insect, causes this kind of kissing lesion, can help to diagnose it. So blister beetle dermatitis does occur in Virginia. There's some things that get animals that are faulted in Virginia when in fact that may not be the case. So as an example, 59-year-old female, past medical history of alcohol use disorder, polysubstance abuse and malnutrition, presented in June with a 5-day history of painful left lower extremity wound. Very classic for some of my toxicology patients and addiction patients. The patient reported an insect bite on her left lower extremity while sleeping in a park bench. She was homeless with development of immediate pruritus, redness, mild swelling at the bite site, no history of trauma. The next day, the patient developed a blister associated with the pain and redness at the bite site. 2 days before the presentation, the blister ruptured and developed into a black eschar. The patient reported associated fever, diaphoresis, nausea daily for 3 to 4 days. She's a smoker. Occasional cocaine use, drinks a fifth of vodka daily for 11 years. The patient denied any history of IV substance use or skin popping where they sub-Q inject their drugs. Patient denied any travel history and lives in Southwest Virginia only. On examination, she had a necrotic wound on the lateral aspect of her lower leg, 5 to 10 centimeters, associated with swelling, erythema, warmth. There was significant tenderness to palpation. Lab workup was unremarkable. Urine scrub drug screen was positive for cocaine, opiates, benzodiazepines, and cannabinoids. CT scan showed subcutaneous edema with fat stranding, suggestive cellulitis, negative for necrotizing fasciitis or osteo, and she was treated with broad spectrum antibiotics. And her lesion looked like this. And she claimed, and initially they claimed a concern for this animal. And this animal, which is also known as the fiddleback, is the brown recluse. So brown recluse spiders are characteristic with this violin-shaped markings on their back. However, there are other spiders that have that too in Virginia. The bodies are 1 centimeter long and a half centimeter wide. Typically, males are slightly smaller. And the characteristic, if you look at this one, and this is actually a true brown recluse that was brought to me to see once if the house had an infestation. This spider actually has 3 sets of eyes and not 4 sets of eyes. And this is an actual brown recluse from someone who moved from Kentucky, and the spiders actually traveled with them. So true brown recluse, but not living in Virginia. So these are spiders that get brought in. If you look at where the recluse range is, it's outside of Virginia besides potentially the furthest southwest tip. Talked a lot with the medicine naturalists about this. unless it's brought in from another range, it should not be indigenous to Virginia. It has sphingomyelus D, which is responsible for the dermonecrotic lesions. Most envenomations are minor with no dermonecrosis. Some people do get loxoscelism, condition where the skin around the bite dies, and some people get systemic to the point of hemolysis and DIC, primarily reported in children. You should be aware, however, and I would say this is absolutely true in my practice, Vetter, Richard S. Vetter, has done a lot of research in this area and has actually shown that most of the times people diagnose a brown recluse bite, later on that's corrected and it's not a brown recluse bite, like the patient I presented. That was not a brown recluse bite. And they put together a mnemonic device to avoid false diagnosis of brown recluse spider bites called Not Recluse. This was published in 2017 in JAMA, and he is really the world's expert. He's done a lot of good work on brown recluse bites. I won't read all of this. I want you to be aware that this exists. It's sometimes hard to convince your patients they were not bitten by a brown recluse. I still get consults at times at the University of Virginia with consideration of a brown recluse bite, and it's often a dermonecrotic lesion from something else that occurs, not a brown recluse. But I think Vetter has done a very nice job with this, and this is, again, a paper that can be used very easily with a scoring system that actually it is not a brown recluse spider bite, and they're not indigenous to our area. The treatment for these, there's not a lot you can do, even if you did know you're bitten. A lot of things have been tried. People have excised these. They've used steroids. Dapsone's been tried, HPO or hyperbaric oxygen, colchicine. Even they've attempted to make antivenom, and nothing has really worked for these. I think the biggest problem is just correctly diagnosing these. So I would not make, I'd be very cautious out there in a dermonecrotic lesion to claim that that is a brown recluse bite. And you should really think of other things on the differential diagnosis. Comically, I will always recall that after 9/11, when anthrax was released, one of the first cases of anthrax in a child was misdiagnosed as a cutaneous anthrax in a child, was misdiagnosed as a brown recluse spider bite initially because of the dermonecrosis. So again, be careful out there and do not misdiagnose dermonecrotic lesion as a brown recluse. However, we do have a spider that causes problems in Virginia. And this is a case that I had a number of years ago. I will get a few of these cases each year that get admitted to the University of Virginia, and the pediatric cases tend to be transferred to us. 15-year-old presents with a complaint of being bitten on the foot with a spider that when she placed her bare foot in a tennis shoe. So she had her tennis shoe in the garage for a while. She even shook it because she was worried if something was in it, which probably just angered the spider in its web. And then when she put her bare foot in the shoe, the spider bit the dorsum of her foot. They came to the pediatric emergency department with a dead spider, and they with some erythema of the back of the foot. The mother who was with the child was very bright, and we wanted to watch her for a longer time period. She said, "No, I can watch her at home. If we get worse, I'll come back." She did come back a number of hours later after they got discharged. She had severe pain of her lower leg. She had abdominal pain, had vomiting. Her blood pressure was high. Her pulse was high. She's tachypnic. And this is very characteristic of a black widow envenomation. So black widows, one of the few spiders that have a venom in the United States that can cause systemic symptoms. You have a pinprick sensation potentially. You get local swelling initially, some erythema. If it's really early, a unique characteristic of a black widow, and it only had a few cases that have come in this early, they'll get erythema, but at the site of the erythema, it causes the sweat glands to release. And so they're dripping sweat where it's erythematous in that patch. And it's really unique for a black widow. As time goes on, the venom follows the lymphatics and starts to get into the systemic circulation. And so the extremity that's been bit will initially have spasms and pain, but then it goes on to chest and abdominal. And I've had some cases, only one case in my career where it was so severe, the spasms, it was almost like a tetanus, and we ended up having to intubate the patient and put them on muscle relaxers, high dose Valium, to get the spasms to resolve. One case in my career. Most of the time, that does not get to that severity. You can have a headache, nausea, vomiting, shortness of breath. You get hypertension, tachycardia, tachypnea. And typically, I find that most of my patients, the symptoms will improve 48 hours out, and then I'll discharge them from the hospital. But during that time period, if you think about the worst Charlie horse you've ever had and multiply that by all the muscles of your body, that's how it's been described to me. Just severe spasms throughout the body. Why does this happen? Well, the black widow, you have the presynaptic neuron and the postsynaptic neuron, and then you have neurotransmitters that are contained. There's calcium that's allowed into the presynaptic neuron. It's a voltage-sensitive calcium channel. The calcium will come in, and during depolarization, allow the neurotransmitters to be released. Well, alpha-lactaltoxin is the toxin that's in the black widow, causes those calcium channels to open, not by depolarization, but just directly. Calcium floods in, allowing fusion of the neurotransmitter vesicle to the presynaptic neuron, and the neurotransmitters are released. And it's released at neuromuscular junctions such that you start to get spasms. You get these cramps. You're constantly having acetylcholine hitting those synapses, as well as other neurotransmitters, which is why you get hypertension and tachycardia. So how do we treat these? You can put some ice to the bite site. I would say a minimum of 4 hours of observation to see how it's going to develop. If it stabilizes, they could potentially be discharged. If it starts to get severe, I would start with acetaminophen, but typically you're going to have to progress to opioids and benzodiazepines. I think diazepam works well. And so I usually am using hydromorphone and diazepam until I get the spasms under control, their pain under control. I will use NSAIDs also, and then I'll switch them to orals and get them discharged and follow them up in my clinic. It used to be thought that you could give calcium and that would be of help. The studies have not supported that, and that should be out of most of the textbooks now, except for some of the older textbooks. Do not give calcium. There was an antivenin, and early in my career, we had access to it as horse-derived. It was quite dangerous, actually. A pretty significant percentage of patients would anaphylax to it. It was a full antibody that you would be infusing. However, it worked really well. And so whenever we would give this antivenin, we would assure there was an epi drip hanging in case they anaphylaxed. Was just at our scientific meeting for toxicology, and they recently had a case of a pregnant female who was bitten by a black widow, who they actually did have some of the antivenin, were able to get it, and gave it to her with really good effect that kept her from going into preterm labor. So there is some antivenin out there, not very common because Merck doesn't make it anymore. But I was surprised at the national meeting that there was a case where they were able to find it. But you have to, again, be careful and prep for anaphylaxis if you were to use it. Fire ants also exist in Virginia. Many of them were not indigenous and were brought in. I just want you to be aware that these are there. I had a miserable time with one of my kids once who actually stood on one of these. I didn't realize it, and he was screaming when he was younger. And I felt terrible as a parent because then I finally realized why he was kind of throwing a fit, because he had these fire ants that were crawling on his legs. From where he is standing. So they tend to bite with their jaws, and then they have an envenomating apparatus on their belly that's very similar to the honeybee. Then it has agents in its venom that are very similar because they're similar in species. And so you can actually have anaphylaxis to these, to fire ants if you have a bee or wasp allergy. Otherwise, it's going to be cool compresses. And you're going to look at potentially steroids, but H1 blockers, like you would treat any allergic reaction. Now, I'm going to pause there for a moment as we get into a few other things here that are envenomating out in nature. There's two studies I've done with residents and students. Joe Forster actually was a medical student, went to the University of Virginia. He now is a cardiothoracic surgeon at Stanford, phenomenal individual and a true alpinist. We did a study of injury and illness encountered in Shenandoah National Park, and then we did a subsequent study using the CDC's Wonder database, looking at fatalities from venomous and non-venomous animals in the United States. And the one thing to be aware of, if you are a medical person in the wilderness and you're with other people, the most life-saving treatment that you can have from things that envenomate is going to be an EpiPen auto-injector. There's certainly bee and wasp stings are result in a lot of deaths in the wilderness. And so when I take the students with me, the two things medically that I do on day hikes, I always have an EpiPen auto injector. I also carry an albuterol inhaler because my students with asthma often forget it, and we're halfway up the mountain when they start having an asthma attack. So just thinking through as a medical provider, what do I want to carry with me? But for things that envenomate, think about having an EpiPen auto injector with you. That is going to be one of the most life-saving medications you can have with you in the wilderness. Ticks. I wasn't planning on talking much on ticks. Dr. Moore and I talked a little bit, communicated. And there's two things with ticks to be aware. There's a lot of diseases. Certainly, when I hike in the wilderness and with my family, it's probably the thing I worry about more than anything that's out there are some of the tick-borne diseases because they're quite prolific. Ehrlichiosis, Rocky Mountain spotted fever, Lyme's disease, starry. I mean, there's a whole list of tick-borne diseases that are out there. And I've certainly have had plenty of ticks on me in the past. One thing that's unique, and this was from the New England Journal of Medicine, these pictures, these are not my pictures, and I should have cited it at the bottom, but what they depicted here, and I've had two cases in my pediatric practice, it's a young girl who came in with problems walking, and when she was examined, she was found to have proximal muscle weakness, but had ascending paralysis. And what they are depicting in the picture is they actually found an engorged tick on her, and once it removed, she steadily got better over the next 48 hours. And this is tick paralysis. And I think people forget that this exists worldwide and in Virginia. There's 43 species of ticks that cause. Most cases are in children. And in my practice, again, I've not seen many of these cases, but they've all been in the pediatric realm. Signs and symptoms, it's a number of days after the tick attaches. Like most of the diseases, they have to be able to regurgitate. And what you'll find is it's a failure of release of acetylcholine at the neuromuscular junction. You'll get ascending paralysis. Typically, the two cases that I saw was acute ataxia was the initial complaint that they had. And you'll find that their deep tendon reflexes are actually diminished. Be very careful on anybody who comes in where you're thinking it's Guillain-Barré during the months where ticks are out. You really need to make sure you look head to toe to make sure there's not a tick attached because it would be a horrible thing to miss when in fact you can actually cure them if you are able to find it and remove it. And you can imagine with her hair as thick as it is, that would be a challenge to find it. I give them a lot of credit for finding that tick on her. My kids were all blonde, and in the summer times, my wife and I would actually cut their hair quite short so that we could look and find ticks more easily on them when we're out camping and such. The other thing that was discovered at the University of Virginia was alpha-gal syndrome. And alpha-gal syndrome is a tick-borne illness causing an allergy to a sugar molecule called alpha-gal found in red meat and other mammalian products. It is triggered by the bite of certain ticks, primarily the Lone Star tick depicted there, and they can have delayed allergic reactions. And often they'll get digestive issues. They'll eat red meat and really have trouble with diarrhea, nausea. They can get hives, and you can get anaphylaxis. And it's something to keep on the differential for people who talk about changes in the impact when they do eat red meat. And if you look at the maps on where this is diagnosed, we have a high number that are diagnosed here. Now, part of that might be reporting bias because it was discovered here, but certainly something I'm aware of, and I'm very glad I have not developed this. Also, and what Dr. Moore had pointed out to me was this that just got published. Platts Mills is who discovered this, phenomenal physician and researcher. And this was a New Jersey man who actually died. And it was not clear why he died, and they did some phenomenal work actually showing that it was actually alpha-gal that led to the death, and he actually died from anaphylaxis after eating a red meat meal. And so, again, be aware, this is out there, and certainly we are seeing problems with this out in our population, and it's broadly showing throughout the United States now too with alpha-gal. Snakes. So lots we can talk about with snake envenomations. The stories are really pretty phenomenal. I always have enjoyed my patients who have been bitten by snakes. It's because of the stories that come with them, and just some of the novelty to these cases. And this is one example. So this individual, he was walking down a country road, and there was a timber rattlesnake that was dead on the road. Now, when you're on roads and asphalt and you see a snake, it's not necessarily dead. It's warming itself on the blacktop. And my wife's family is from Bozeman, Montana. And when I was dating her, having come from Michigan, for the first time, I was going to go out for a run. And my wife's father said, look, if you see a snake in the road, make sure you give it wide berth. It's not dead. People often will think it's dead. And my wife actually later tagged me and said, hey, that's a good sign my father likes you. And it was actually a valuable lesson that I've never forgotten. And this individual actually didn't know that lesson. So he thought the timber rattlesnake was dead. He wanted the rattle, and so he went to pick it up. Well, it wasn't dead, and you can see where the blue ring is where he was bitten. He actually was flown to us from the scene where this occurred. It was a pretty remote rural area. Pegasus, our flight service, flew him to us. And if you look, he's already got quite a bit of edema and swelling from the timber rattlesnake bite. This is also him. Again, this is right when he arrived by flight. So we're about an hour, maybe 2 hours out from the envenomation. You can see his hand where it's kind of dripping there. But what you also see is up on his right arm, all these striae. And if you look at that a little closer, you can see those are really petechiae. And the reason he has those petechiae, that is where the blood pressure cuff was. And the reason that he has that is he had no platelets. So within 2 hours, he had lost all platelets and was developing petechiae in any areas where there's any pressure on his skin. And this is pretty characteristic of a timber rattlesnake envenomation, a significant one. And I've seen a number of these cases that come from the scene where they're platelets. You get the initial platelets, and they're basically zero when they come in. This is him. Arm circumference increased by 4 centimeters in an hour's time period, going all the way up his arm. This is another one on day 2. You can see the blebbing. And if you think about rattlesnakes especially, but other snakes too, their venom is not only meant to incapacitate their prey, but also to help digest their prey. And what's basically happening is the fat is being digested. You see a lot of bruising and a lot of bleeding, and I'll show you some slides at the end of an autopsy. And that's because the capillaries are damaged. There's no platelets, and he's bleeding into his tissues. It's day 5. You can see again, a lot of bruising. He's got a lot of swelling, despite a lot of antivenom that he received. And this is him on day 6. And again, a lot of blood loss into the area, despite a lot of platelet transfusions and a lot of antivenom that was given to this individual. And again, characteristic for a timber rattlesnake bite, the worst snake to get bitten by from my standpoint in Virginia. Now, the Virginia snakes, there's four, really three species of snakes. We have the northern copperhead. We have the cottonmouth, that's by the Great Abysmal Swamp. That's not by me in Charlottesville. You have the canebrake rattlesnake, which is really the same snake as the timber rattlesnake. They're just geographically located in different areas. So the canebrake is down by the Abysmal Swamp. The timber rattlesnake is by us in the mountains. Now, by the University of Virginia, by our campus that we call grounds, we have copperheads, and I've had one student bitten by a copperhead. We do not have timber rattles here. So depending on where individuals are envenomated, I usually have a fairly good idea of what snake that might be. As we get to the mountains, there's more of a risk that it might be a timber rattler. Certainly, again, I don't have cottonmouths here. I also always have to chuckle a little bit when I look at the Latin name, the scientific name. Certainly the early settlers and those that named, the scientists who named this snake, thought it was horrible to call it Crotalus horridus horridus. So large snake causes thrombocytopenia, causes significant tissue damage. Now, I don't encourage you to get this close to snakes to be able to figure out if they're venomous or not. There's a lot of mimickers of copperheads that are out there, and sometimes it's really hard to depict unless you get really close. The crotalids, which we have in Virginia that are venomous, have a slit-like eye, not a round eye. They have a triangle-like head, sometimes hard to depict. And then if you were to flip them over, which I do not encourage you to do, the venomous with the copperhead have a scales in a single row, whereas the non-venomous, the caudal anal plate has scales in a double row. And of course, the timber rattler has a rattle. So the majority of our envenomations that we see in Virginia and what we have in data from the Blue Ridge Poison Center are going to be copperheads. Over 90% of the calls we get are related to copperhead envenomations. Partly there's a lot more copperheads. They're more prevalent throughout the state. They don't have a rattle, and so there's not the warning people get. There's nothing worse than hiking and hearing the rattle, not exactly knowing where the snake is at the time when it rattles, but it certainly stops you dead in your steps and allows you to back off when they rattle. That's not true of copperheads. The fangs are like hypodermic needles. This is a close-up of some of the fangs that will inject very quickly into your subcutaneous tissue, and they do not go very deep. The habitats of the snakes, they prefer the 80-degree temperature range. Certainly right now, this time of year, they are no longer out, which is really, from my standpoint, a delightful time to hike. It's colder, less ticks, less snakes out there, a chance. In the summertime, because of the heat, they tend to be more nocturnal. That runs into problems with people who go outside to, for example, walk their dog, or their dog's barking, they're not sure what it is. I've had a number of patients who went out in bare feet and then got bit. I had one young adult who was walking with her parents, both physicians, turned their flashlights off to see the stars and stepped right on a timber rattler. So being careful on where you step, being careful on what you put your feet, knowing the optimal temperature ranges when they're out, all are helpful. And knowing this time of year, you're not going to have a problem with being envenomated unless the day really warms up. There's an epidemiology of snake bites and somewhat of a famous study done by Steve Curry, who I think is one of the more phenomenal clinical toxicologists, good friend and colleague. He published this in 1989, early in his career. And they just did a study of snake envenomation patients. And there's some truth to this yet. High percentage male, less female. The ages between 18 and 50. High percentage associated with alcohol. And I would say early in my career that was true. I think it's less so now, and I'll come back to that in a minute. When we talk about illegitimate bites, illegitimate, he defined as they weren't minding their own business. In other words, they're trying to pick the snake up or they're doing something with the snake as opposed to I was just gardening and got bit by a snake. So the alcohol, I would say my snake envenomation patients, the ones associated with alcohol have diminished. And that's because we're seeing a lot more people getting out and involved with nature. And so there's a lot more innocent bites that are not illegitimate, or in other words, people who are intoxicated with alcohol who are trying to pick the snake up and have delayed reaction times. Different clinical effects from our snakes. Again, we're talking about the crotalids primarily in the United States and certainly in Virginia. Local tissue damage, gets swelling and necrosis, coagulopathy, and neuromuscular blockade. Now, the neuromuscular blockade occurs with the Mojave rattlesnake out west, but we do have the timber rattler does a thing called myokymia, where you get spasms of muscles in the area, or kind of a worm-like motion of muscles as their neurotransmitters are firing off. And it's kind of a unique thing that we see with the timber rattlers. And I've had a number of cases that have come in with this myokymia, but we do not get neuromuscular blockade with the snakes that we have in Virginia. So local tissue damage. This is a case with just a dry bite. You can see the two fang marks. They came in to be evaluated because it was a venomous snake. After a number of hours, there's no swelling, no edema, no pain. And the patient was allowed to go home. This was a copperhead envenomation. The estimates are that 10 to 20% of crotalid envenomations, actually, or bites, I should say, do not envenomate. They don't release the venom into your skin. But 80 to 90% do. This one, you can see the erythema on the arm. She was canoeing, reached out to grab roots at the bank, did not see the copperhead that was curled up in there, and it bit her forearm. And this is also her later. You can see the lymphangitis that developed. And I always tell my patients that no matter how much antivenom we give, there's always going to be some of the venom components we can't knock out. The venom goes into the subcutaneous tissue and then follows the lymphatics. And so you're going to get swelling, you're going to get pain, and you're going to get lymphangitis, and you're going to get enlargement of your lymph nodes. All to be expected. It's not infected. And with time, it will start to resolve. And she had kind of distinct lymphangitis from the inflammation that she had as the venom was following up with the lymphatics. Now, copperhead bites can be severe and can cause pretty significant necrosis. This was a patient of mine a number of years ago, was gardening, went to pick up a rock, didn't realize there was a den of a copperhead underneath it. So when he put his hand under the rock to clear it out of his garden, he put his finger right into the copperhead that bit it. He did not get antivenin and came in late, and you can see the amount of dermal necrosis that he has with this. This was a couple days later. He actually followed up with plastics. They were thinking about doing a flap, and actually this healed very well. And he needed no grafting with this. And I point that out because these can look quite bad, but they tend to heal and do fairly well with the copperheads. I didn't put it on my talk. I used to have it in my older talks. There was a study done in the 1980s by Virginia Commonwealth University that highlighted not giving antivenin to copperhead bites, and they all did well. It was a large case series that they did, and they did it at a time when we had the old Wyeth antivenin that was a pretty significant risk of anaphylaxis too, the old horse antivenin. But the copperhead bites, you can certainly get necrosis. You can get digit loss. I've rarely had that in my career, but I just realized they typically will do well, even if they did not get antivenin, though without antivenin, it would take a much longer time period to recover. The venom contents are very complex. And it's going to vary from snake to snake. It depends on the nutritional status, the age, when was its last meal. There's just a whole host of factors that come in that make it, what it's going to inject in you. This is a partial list, a lot of enzymes that are going to digest tissue and digest and damage the capillaries and cause bleeding into the tissue. There's one study that was done a number of years ago. This was Sovah, and I like this study because it helped to explain some problems that I had with my snake bites. So if you think about venom, venom gets injected, induces edema, ischemia, necrosis. The venom actually has venom metalloproteinases, and these venom metalloproteinases release tumor necrosis factor alpha from pro-tumor necrosis factor. And that sets off our own endogenous pathways of inflammation with our own human metalloproteinases. That actually adds to the local tissue damage and necrosis. The reason I like this as part of the theory of why when we give antivenom, the longer we wait, the harder it is to control some of the swelling and damage that's done. And that's because the antivenom will knock out the venom metalloproteinases, but not our own human or our own inflammatory mediators once these cascades get set off. So what does this mean? It means that those who've studied snake bites and looked at this in the animal models, if we give the antivenom before they envenomate the animals, those animals do actually really well because those enzymes in the venom metalloproteinases are stopped immediately. As time goes on, though, it's harder to release some of our own endogenous inflammatory mediators. Plus, there's some things the venom can't completely take out. And so you'll see it harder to control the edema. We also have the problem that some of our bites are actually pretty mild and don't need antivenom. But it's hard to predict early on after the envenomation. And so I find our snake bites are really difficult to determine early on if they come in the first hour. Do I give antivenom? Do I not give antivenom? I have a bias, and I always like to treat my patients how I'd want to be treated. I have good insurance. I really do not want to be held up if I get bit by a copperhead and not be able to work as a physician for a number of weeks because I have so much edema, ischemia, and necrosis. And so I'd rather get the antivenom earlier than later. But it's very expensive, and some people might not need it. And so there's this balance I always have in my mind of, do we give it, do we not give it, and at what point do we give it? And I think that's one of the challenges we all have. I'm very conservative with a hand. If I have a hand bite, I have a finger that's envenomated, I will tend to give it earlier than later. I don't like to wait long because if it starts to get really swollen and I don't get good flow to those areas, it's harder to get the antivenom to those areas. So, and I do know you can run a risk of actually losing a finger if I have a significant envenomation of a single digit. So if I have a lower leg envenomation, there's just a little bit of edema, I may wait for a while to see how that progresses. And if they're doing okay, don't need narcotics, I'll hold off and not necessarily give the antivenom. It's a high balance, and I always follow these cases up I have a clinic that I follow these up on the next day to make sure that they're doing okay. But again, I'm erring on the side typically of the antivenom because we do know it arrests this cascade. Now, the other is venom-induced coagulopathy. There's 3 different syndromes that I see with snake envenomations. There's venom-induced thrombocytopenia. We do not see that with a copperhead, but we see it with a timber rattlesnake. It's somewhat unique for snakes, meaning that we don't see any problems with fibrinogen or fibrin split products, the PT or PTT, but the platelets drop precipitously. There's benign defibrillation, meaning that the fibrinogen may go down, the fibrin split products are up, PT and PTT may become a little prolonged, but there's really no overt bleeding, evidence of red blood cell destruction, and infarction. DIC for our snakes is exceedingly rare. I've only had a couple cases where I could really say it was DIC. I had a 15-year-old who was bit on the foot who lost a large amount of her blood volume by a timber rattle. I also had a young male who at the campfire with his friends saw a timber rattlesnake crawl into the light of the campfire. His friends who were drinking, and he was drinking alcohol, dared him to pick up the timber rattler, which he did. He got bit on his hand, he got bit on his upper arm, and he got bit on his chest wall. And then he finally let the timber rattler down. He was flown to me by Pegasus, was in my intensive care unit for 10 days, intubated with marked coagulopathy, marked necrosis in the areas where he was bitten. But he was bitten by 3 times by the snake, marked envenomation that occurred with him. Those are the only 2 cases I've ever had at DIC. I've had a lot of venom-induced thrombocytopenia. Copperheads, I might get some benign defibrillization, but rarely anything. In fact, I'm at the point in my career now with the amount of snakes envenomations I've seen. If it's a confirmed copperhead, I don't check labs. I'll watch, see if they need antivenin, and I will follow them up. But certainly feel free to get labs. I think that's the standard. But I've gotten to a point in my career, I just do not find labs are helpful in copperhead envenomations, documented copperhead. Now, pre-hospital care, lots of myths with snake envenomations. And this comes from a 1968 book from California. And their recommendations were apply a constriction band or tourniquet, capture the snake and kill it, lie down, make incisions through the fang marks and apply suction, administer antivenin in the field, transport the victim to a medical facility, and institute supportive measures. And I'm going to put out there the only things they really have correct on there now are number 6 and number 7. So a lot of myths with pre-hospital care. We've published quite a bit on this in the past, and I've spoken on this in public arenas too. You can immobilize. So again, going to wilderness medicine, what I carry in my backpack, I have 2 SAM splints in my backpack with ACE wraps. So if someone was bitten by a venomous snake, I would, for comfort, put them in a splint, ACE wrap them, and then get them to the hospital. But I'm going to rapidly transport them to be checked to see if they need antivenin. Don't apply ice. Actually, they can cause more harm. Don't apply heat. It does no benefit. Do not do a tourniquet. I've had patients who actually would have done well from their copperhead bite, except they put a tourniquet on for a prolonged time period and then had problems secondary to the tourniquet. Incision and suction, so there's no reason to incise a wound. And suction, believe it or not, there were military studies done in the 1950s showing harm by applying suction in the animal models that they tried. Electric shock therapy may seem strange, but there is actually a letter to the editor in the New England Journal of Medicine in the 1990s, I believe it was, that talked about using electric shock therapy to denature the enzymes. And for whatever reason, Outdoor Life at that time picked up that article and really expounded on people should be bringing tasers out in the wilderness and tase them and put electricity to the wound. And then there were some pretty abysmal cases that actually got electrocuted when they were trying to treat the snake bites themselves. So some historic things that get put out there that actually have been disproven. There are actually some really good studies that came out in animal models after that showing that electric shock therapy did no benefit. There's also products out there you can buy in various stores. So the product up above is a snake bite kit, and what you see there, it comes apart. The 2 yellow parts, there's betadine, there's a scalpel, there's a shoestring, and there is that kind of suction device. All things you don't want to do. The extractor, really interesting when you get into where they say there's evidence for this. Believe me when I tell you there is no evidence for that. The extractor, it actually makes no sense to me whatsoever. So do not waste your money on these products, but they are still sold in various stores such as Walmart's and Dick's, sporting goods, things we do not want people to do. We published a number of years ago. This was a copperhead envenomation. The father had it at Sawyer extractor. He put it on for 20 minutes. And if you look at where the necrosis is, it's in a perfect circle where the extractor was because the tissue was damaged by putting the suction device on there. it actually caused more dermal necrosis in the snake envenomation itself. So again, do not use these devices, and I would avoid them certainly, and do not waste your money. So what do you do? Pre-hospital, people don't like to hear it, but there's not much you can do. Right? I can splint them, bring them to healthcare. Just don't do any of these other treatments. Once they're in the hospital, often people will have vomiting. Make sure they're well hydrated. Wound care. I find that elevation is important. You're going to get a lot less pain. If you think about it, the capillaries are damaged. They're starting to leak out. And you want to keep those extremities elevated. You want to mark them very clearly. I'll show you an example. And I watch the spread. I also do circumferential measurements of the extremities to see how fast the circumferential measurements are increasing. Prophylactic antibiotics. Don't need them. The studies clearly show that. Yes, it is inflamed. Yes, you do get lymphangitis. Yes, you do get big lymph nodes. It's all inflammatory from the venom itself. There's no reason for antibiotics. I've rarely had cases that had infection associated. I had one person who had severe peripheral vascular disease and diabetes, had a severe envenomation and developed a secondary infection about a week afterwards. And that is the only case I've had. Analgesia, acetaminophen I'll start with. Opioids, hydromorphone I usually will use because the pain is significant. If I'm using IV or I'm using hydrocodone or oxycodone orally. We say avoid NSAIDs, such as ibuprofen. Now, I said there's a big inflammatory reaction. However, there's also the issue of platelets and platelet dysfunction. And we have debates in our circles. In fact, my own team has debated this. I'm not willing to take the chance. I don't want more bleeding in the wound, and I just don't see a reason to give NSAIDs. And so I think most of the reports out there, unless we find other evidence, physiologically, I avoid NSAIDs early. Later on, yes, I will put them on NSAIDs for pain. Steroids, again, if you have an inflammatory reaction, you would think steroids would be a benefit. This goes back decades. They trialed this and it didn't work. The only thing that the steroids are for are if there's serum sickness that occurs from the antivenom, which is exceedingly rare with the antivenoms that we give. Copper envenomation that we had, you can see where the fang marks are. They're circled. You can see the swelling on the ankle as it's going up. It's timed. We use a surgical marker to time each time we measure where the leading edge is. I didn't show on these pictures, but when I do circumferential measurements of the leg, I mark with this marker exactly where I'm using the measuring tape, and I use an OB disposable tape for that. The reason you want to mark exactly where it is for subsequent measurements. You want to know exactly where you measured the circumference before and how fast is it expanding, and do we have a control? Now, I'll put out there, like with this envenomation that was from that copperhead, we give the antivenin, and then we watch to see how fast the progression is proximally and distally. So we want to see control at where the envenomation site is. There will be some proximal spread, no matter how good the antivenin. There's some venom components we're not knocking out, and there is going to be some venom spread, but it's a matter of how fast do we delay it, and are we getting some control with the pain? And there's, again, a bit of an art to this for us as we talk with the hospitals that we cover, and when I see these patients too, and we get a lot at the University of Virginia. Fasciotomy, not indicated. I can't stress this enough. There's been a number of studies that are done with this, and one of the first studies that was done was actually Finley Russell, who was on it as an author. He was actually the father of antivenin. The first antivenin that came out was what he developed as a scientist. And there was a debate that went on for some time between the surgeons and those who were using antivenin. That's because there was a surgeon by the name of Glass who did a number of publications from Texas, where he did hundreds of fasciotomies and they all did well. There's no control group, And Finley Russell came out and said, well, I treated a lot of patients with Ativan and they all did well too. And so back in the 80s, there was this debate that was going back and forth until this article came out. And he did this with the surgeons, his institution. Basically, they showed that ativan and fasciotomy did not prevent muscle necrosis. Ativan and decreased compartment pressures decreased muscle strength in animals that received fasciotomy. And basically, that routine fasciotomy that Glass was recommending was not to be recommended. And there's been a lot of studies that have come out on this since that time. Now, certainly, if the intercompartmental pressures are markedly elevated, yes, you can consider the potential for using fasciotomy. Certainly, I would use anivenin first. Some people will try mannitol one dose. It's with the thought being with the osmotic changes, similar to what they do with post-embolectomies, you might be able to decrease some of the pressure. But I have not had a snake bite in Virginia where I've had to do a fasciotomy in 26 years. I've had 2 snake envenomations where they did a fasciotomy and really regretted it because they didn't heal well because they're cutting through damaged tissue to begin with. And so I'd just be very cautious. I think this news is certainly well out there. Early in my career in the 90s, there was huge debates on this yet. But we're seeing less and less fasciotomies done, and it's very, very rare I'd ever consider one. There's 2 types of anivenin that are on the market. And this is the other good news, that when I first started my career, we had an anivenin called Wyeth anivenin. It was a full antibody that came from horses and a high rate of anaphylaxis that came from that. Subsequently, Crofab was developed, and then Anavip was approved in the United States. So we have 2. So I'm glad we have 2 that are competing to try and lower the prices because these are not cheap. I do not feel strongly one way or the other which one you have. There's benefits and detriments to each one. It's just about dosing. Realize the thing to know that if you have Crofab, you have to ask people, are you allergic to sheep? If you have Anavit, you have to ask them if they're allergic to horses, because that's where these are derived from. You do need to ask them if they have an alpha-gal allergy. These are antivenoms that are derived from animals, mammals, and they will have an allergic reaction to this. We did have a case with a significant alpha-gal allergy. We tried the infusion, and they developed allergic reaction immediately to that. Pineapple and papaya, you have to ask too. My patients always look very confused at me when I ask them, are you allergic to papaya or pineapples? And the reason is when you look at these, the Fab antivenin, you can see with Crofab is papain cleaved, which comes from papaya. That's different than Anavit, which is pepsin cleaved, and you get this Fab2 antivenin. So just realize, depending on which antivenom you use, you need to know what to ask them about allergies. And have I ever had anybody say they have a papaya allergy? No, but you should still ask the question. Now, if I don't I'm going to finish up, and I apologize if these are a little gruesome, but if you do not get antivenin, realize you can die from snake bites. And this is a depiction. Decades ago, I was asked to watch an autopsy in Virginia of someone who got bit by a timber rattlesnake and did not seek care. And you can see a lot of bleeding in the chest wall. He was bitten in the chest wall. He had been bitten in the previous time with some necrosis of his thumb, has petechiae, so on autopsy certainly had thrombocytopenia based on what we saw with the mucous membranes. It's a pretty big spread. That's an inch wide fang. So this was a big timber rattler that bit him. He was handling the snake. And what I'm showing here, and again, gruesome, but you can see how much blood loss there is in the tissues. And so without platelet infusions and without antivenom, there is a risk of death from snakes in Virginia. So certainly people should seek medical care. Now, before, when I had come, I said we have a newsletter. We talk a lot. We routinely, pretty much every month, we put out a new newsletter regarding new substance of abuse that are occurring out in society. But we also do newsletters related to nature, snake envenomations, black widow, the antivenoms we have and such. So if you want to subscribe, feel free or contact me directly. My email is on the talk too. And with that, I'm going to end and stop sharing and see what questions you have.
Mary, what do we have?
Okay. Let me see. Brittany Piloto asked, she said she read a report recently, and I apologize for not remembering where, that said in parts of the US, rattlesnakes are starting to not give warning rattles. Is that something you've run into here?
Yeah, it's interesting. I've heard that too. And part of it, I'm trying to remember why they're thinking this is. Whereas it used to keep predators away, it might actually attract them. And you're absolutely right. I heard the same story. That is worrisome. I'm not aware of that with the timber rattlers. I've encountered a number of them on hikes. Fortunately, my family, my kids have never been bitten by these snakes. I'm actually more worried about copperheads because they don't rattle. Actually, my son's dog has been bitten twice by copperheads. You know, they make noise, the dog dives after it and gets bit, and believe it or not, it got bit twice. First time we brought it to the vet, I felt terrible about it. And the vet said, yeah, not much to do. And the next time I got bit, I did bring him to the vet and did well. So, but certainly concerning if they're not rattling, because that I do think is a benefit for us when there's they rattle, keeps us away from them.
Okay, the next question is from Dr. McIntosh. She says, good evening, everyone. Another superb presentation. What are the long-term psychological and physical rehabilitation needs for patients with significant envenomation? Thank you.
Yeah, no, thanks for that. That's actually, that reminds me, there's one thing I forgot to tell you. So rehabilitation, I have two sons who are physical therapists, and we actually did some work with a physical therapist here because we, with the snake envenomations, most of the data that's out there is just about the acute phase, but not long-term. So some things that we've seen in our clinic long-term, one is intolerance to cold. They, for whatever reason, it seems like their vessels just do not work as well. It's like a Raynaud's type phenomenon, and that's anecdotal. I don't have a study on that. The other is be really careful with leg envenomations. What I have found, and I'm kind of obsessive about this now, if you're bitten, we give you antivenom, you have a lot of pain, you're sent home, we have you in a splint. The splints aren't overly comfortable. What do? Well, I'm watching TV and I have my leg elevated on something. And then what happens is you get plantar flexion, right? Your foot just drops. You don't really pay attention to it. And so I had a lacrosse player who sat and watched TV for a week and actually got an Achilles contracture. And I felt horrible about it. They didn't wear the splints, and we've actually done some changes in regards to splints. But I always tell my patients that, look, you can take off your splint, but you have to, the majority of the time, keep it in dorsiflexion so you don't shorten your Achilles. So one of the long-term complications that I worry about, so really watch your leg envenomations for that. The other one that you mentioned, psychological, it's a great question. I don't know the answer. I would think there would be a little post-traumatic stress from that, but I don't know that that's been well studied. I think it's ripe for studies long-term because we haven't really thought about that component, but good question.
Okay, the next question is from Dr. Dupre. What was the final diagnosis of the homeless woman causing the necrotic lesion?
It was infection, and she wasn't honest and was doing some skin popping. So that's partly why I wanted to present that one. More than often than not, I'll get some of my patients that will say, no, that wound, I got a spider bite. It's like, yeah, no, it's not. And you got to be careful with our substance users too, especially if they're injecting for necrotic lesions. But it was infectious, and I trying to remember if that was a MRSA infection that caused that necrosis, but was not a brown recluse spider bite.
Okay. So, next question is, what do you do if the patient has an alpha-gai allergy and was bitten on the hand? Give anti-venom cautiously?
Yeah, that's a good question too. Yes, and I'd actually have an epi drip hanging and ready to go in case they anaphylaxed immediately. So I will still try giving the antivenom even if they say, for example, we use Crofab, the Fab fragments, not the Fab 2. And so if they said, yeah, I have a papaya allergy, we would still try the infusion, but we would pre-treat them. I'd pre-treat them with antihistamines, and then I have an epi drip hanging in case we really ran into a problem. But, especially timber rattlesnakes, I'm going to want to try and get the antivenom in. The case that we had that had a significant allergy, we abandoned it and just went with the old Medical College of Virginia, VCU, study and said, look, you may have pain and some necrosis that's going to go on for a little bit longer, but you will recover. And they did okay.
Okay, that is all of the questions that are in the chat.
Thank you, Mary. Dr. Holston, so I think it's obvious, but just to remind folks that the number for the Blue Ridge Poison Center is also the number for help with snake bites and envenomation. So yeah, I'm sure you guys are happy to talk with folks that call you for those reasons.
No, absolutely. In fact, we'll have people can be at home, certainly healthcare providers. We get a lot of calls about things in nature, and happy to help with that. And who needs to go into the hospital, who doesn't need to go into the hospital. We even have the ability for people to text pictures to us on a cell phone with the nurses that they'll fire to me then so that I can take a look at them to see what do we want to do or what does the lesion look like. So no, please use the Poison Center. Give us a call if any questions come up regarding these. Snake bites are complex, and both where they're envenomated, pre-existing health effects, the timing and when they come, and what snake did it. They can be pretty challenging. I've been managing these for over 25 years, and it's each one is a little bit unique in how we manage them.
Okay, I think you just had a question pop up, Mary.
Is there such a thing of long-term Lyme?
Long-term Lyme?
Mm-hmm.
No. I say that there's people who may have delayed diagnosis of Lyme disease who have joint problems and such. And I'll leave this to my infectious disease. I do have one article out there where we did publish a review on Lyme disease, but there's a lot of nefarious behavior going out there with chronic Lyme. There's a lot of people taking advantage of the public, saying they are, and then giving them infusions of ceftriaxone or whatnot out there. I'll leave you with, if you've ever seen the site Quack Watch, you should look at it. Barrett developed it. It's very well done. I use it in my clinic frequently because of nefarious labs that are out there that aren't CLIA certified, that are in cahoots with nefarious clinicians out there who are making money, kind of cheating the public. But a very well done site called Quack Watch. It's got government funding now, I believe, but I use it often in my clinic to show that, look, that lab that said you had chronic Lyme, let me show you, it's not a CLIA certified lab. You can't believe anything that comes from that. We will do testing at the University of Virginia. And most of my patients will accept that, and we'll go through and talk. It actually has providers that are nefarious too, by the way. I'm glad to say my name's not up there, but I have some nemesis whose names are. And I like to highlight them in my clinic that, yeah, see, their name is on this site. They've been thrown out of court. So just be aware, Quack Watch.
Any other questions, Mary, in the chat?
No, that was it.
Well, Dr. Holstead, we're just so grateful for you doing the presentation. I would mention to everyone on the call that we did record this program this evening. It'll be on the external Sovah website. If you have colleagues who weren't able to attend tonight that you recommend to the program, they can certainly listen to it. These recordings do not provide CME or CE credit, but they are there for the betterment of our patients and for the help to our providers. That being said, Dr. Holstead, thank you so much for doing both of these programs. It's just nowhere else you can get this information. It's unique and it's excellent, and we are very grateful. To everyone else on the call, we again wish you a happy holiday season as it begins, and we will send out about mid-December of announcements for the January programs, and we'll continue and as they say, see you next year. So have a great evening and take care and good evening. Bye-bye. Thanks for attending.
Thanks, everybody. Dr. Moore, thank you. Mary, thank you so much. And happy Thanksgiving to everybody early.
Here you go. Bye-bye.